Thank you very much for that introduction. And it's a pleasure to be here to talk about our study that we're working on called Canines and Childhood Cancer. So as Andrea said, I work for the American Humane Association. And for those that are not familiar with American Humane, it is a national nonprofit in the U.S., 135 years old. Its mission is to protect both children and animals from abuse and neglect, as well as harm. And recently, there's been a growing interest in research involving the human-animal bond and human-animal interaction. And the CCC study is definitely an example of that growing interest. So in January 2011, we were funded by Pfizer Animal Health to examine what impact animal-assisted therapy may have for children with cancer. We're also very interested in looking at what the impact may have for the child's family as well. So we added that in as well. But the partnership between Pfizer and American Humane has really been a natural fit since both organizations have a dual interest in human and animal well-being. So the CCC study, we believe, is an innovative research study for several reasons. One is that we plan to do a randomized controlled trial design with multiple sites across the U.S. and possibly abroad. We are going to start with a 6-month pilot, and then after that has been piloted, we will do a 12 to 18-month full clinical trial. We're also, as I said earlier, we're going to focus on the entire family unit, which is pretty, I would say, unique in the human-animal interaction field. So rather than just the child with cancer, we've really discovered that we can't look at one in isolation. We have to look at the entire family. And we're also very interested in looking at what the impact may be for therapy dogs that are participating with this particular population, which is also somewhat rare, as you all know, in the human-animal interaction field. Because we really feel that we can't say anything about the suitability of the interaction without also looking at what impact it may have for the therapy dog. So for the past year and a half, we have been kind of working mostly on site recruitment within the United States, as well as information gathering. So we've conducted a comprehensive literature review, which looks like this, that you can get online at caninesandchildhoodcancer.org. I think it's also available on HABRI's website currently. And then we also conducted focus groups and interviews with 3 of our current sites, with hospital staff there, families and caregivers, animal handlers, and at one site we were able to talk to adolescent survivors. And what we discovered, or what was reinforced, was that childhood cancer is not just a physical disease. It comes with many psychosocial impacts for both the child and the family, including isolation, depression, distress. So that led us to developing these primary research questions. So as we all know and believe in our hearts that animal-assisted therapy can help, and obviously anecdotal and other studies have documented that, we would like to see if we can document with more scientific certainty that these interventions are having a positive impact for this particular population. And again, looking at how the behaviors and physiology of therapy dogs are impacted by their involvement in animal-assisted therapy and activities. So we plan to do a randomized controlled trial design for both children and families and measure biological and psychosocial outcomes. And our site participation is we would like to work with up to 5 pediatric oncology centers in the 6-month initial pilot study, and I'm guessing more will be participating in the full clinical trial. Our goals are to determine the impact for patients and families, to study the impact for therapy dogs, but we'd also really hope to design an AAT treatment protocol that's replicable. One thing we've noticed is that there's no standard way to do animal-assisted therapy or animal-assisted activities. Everyone goes about it quite differently, which is good, but I think what it also does is it creates difficulty in defining what animal-assisted interventions are and trying to explain what actually happens during a session. But it also makes it difficult to study it in a rigorous fashion. So we hope that we can try to design at least something replicable that maybe could be used practically in the future after the study is over. And we also hope to understand how to best integrate AAT into complex pediatric oncology settings. And I think the pilot will really aid us with that goal. So for our hypotheses, what kept coming up over and over again was the idea of distress for children, for families, as well as for therapy dogs. Children tend to experience high levels of distress before a treatment session or actually right during the session. They could be anticipating pain, or they could actually be experiencing pain, which causes them distress. Caregivers tended to experience distress in terms of witnessing their child experiencing that pain, but also outside factors like financial stressors and changes in family life. And what we noticed is that both of those distress from the child and the family are not mutually exclusive. They rub off on one another. And then with therapy dogs, it's a concern, I think, among many animal behaviorists and animal welfare advocates that is the therapy dog experiencing distress. So that's what we tend to focus on, at least for the pilot study, is the concept of distress. And hopefully for the full clinical trial, we can look at more long-term outcomes such as depression or social support aspects. So our hypotheses are that children that experience animal-assisted therapy will experience less distress over the course or throughout their treatment sessions than those that do not experience an animal-assisted therapy intervention. Similarly, for caregivers of children who experience animal-assisted therapy will also experience less distress throughout the course of their child's treatment than those caregivers of children who do not. And then that we also believe that therapy dogs will exhibit or experience minimal distress throughout the course of the study. That one isn't very amenable to the randomized control trial, but it's something that we're interested in looking at. So the project will be in 3 stages. As I said, the stage 1 was site recruitment, literature review, and focus groups, which has been concluded. We're in the 2nd stage right now, which is finalizing our research design, selecting our final clinical sites, and then we will implement, hopefully, the pilot study in the fall. Our 3 current sites, there's 2 in Tennessee, 1 in Nashville, and 1 in Knoxville, Tennessee, and 1 in Florida. But we're also having conversations with the Mayo Clinic and the University of California at Davis, among others. And then stage 3 will be a full clinical trial with more than 5 sites, I guarantee it. And that will happen hopefully next summer. So the children that we're interested in looking at will be children that have been diagnosed with acute lymphoblastic leukemia, or ALL. ALL is the most common type of childhood cancer, and it is also one that has consistent treatment across our multiple sites with the Children's Oncology Group protocol. So we decided to use that diagnosis. And we're also looking at children aged 5 to 11 years. So people have asked us, why only ALL and why 5 to 11? Aren't you limiting your sample size? And yes, we found that that's very true, but the most validated psychosocial measures are appropriate for children 5 or older. And we've also discovered during our focus groups and interviews that adolescents may not be as responsive to animal-assisted therapy as the younger children are. With growing technology, we've heard, oh, they'd rather play with the Wii or the iPod than visit with the animal. So we thought 5 to 11 would be a suitable age group for our sample. The family participants will be anyone that accompanies the child to treatment, so most likely the primary caregivers, but we're also interested in siblings. So we may ask parents to report on sibling well-being because, as we've learned, siblings are highly impacted by their brother or sister's illness. Our sample size is the kicker. It's going to be quite small for our initial 6-month pilot. We're anticipating it'll probably be 20 total children. We had high hopes for it being larger, but it turns out that childhood cancer is not, which is a very good thing, is not as common. Kids are not getting cancer as often. or as frequently as they once were. And so less admissions are coming into each hospital site, which is great for these kiddos, but bad for our sample size. So what that means is that we're probably going to have more sites for the full clinical trial in order to get that N where we want it to be. Another issue that we are currently trying to figure out is how we'll manage random assignment for treatment and control, as well as the cross-contamination that may happen. So one idea is that we are thinking of having children in the treatment group come on certain days, children in the control group come on other days, so that there's not a way that control kids can say, why does he get, Bailey? Why can't I? Because we don't want to cause any undue harm. So that may not be logistic in all cases, but or feasible, but that's what we hope to do. So real fast, I only have 3 minutes left. So the goals are to reduce stress. Our intervention dosage, it's going to be weekly animal-assisted therapy sessions, approximately 20 minutes plus or minus 10 minutes, depending upon the situation. They'll most likely occur in both the inpatient and outpatient clinics in the hospital because of the children's treatment schedules. And most likely, hopefully, in patient rooms, because that'll probably help us to control for the contamination factor. Session participants I already went through, but child, family, animal handler team, and most likely hospital staff may be involved in the session. So to address the idea of ensuring treatment fidelity and that replicable AAT protocol, we've selected a menu of potential activities for handlers to choose from. That then handlers will record those activities after every session with a self-report. They'll receive high training, and our hope is that we can match the same handler and dog with the same child over the course of the study whenever possible. But that will be also a challenge. So we are looking at distress. So how are we going to measure distress? Children, we hope to measure blood pressure, heart rate variability, and behavioral distress through an observational behavioral distress scale. For parents, we hope to look at heart rate variability, their state trait anxiety, so doing the state trait anxiety inventory, and also giving them a measurement called the pediatric inventory for parents, which is a measure that measures a distress related specifically to the child's illness. And then for dogs, we hope to collect their saliva to look at their cortisol levels, as well as in some cases at some sites videotape the session and look at their behavioral cues. Are they avoidance seeking? Are they attention seeking? Things like that. And also handlers will self-report. And the data will be collected on days when patients typically receive their treatment according to the COG protocol. So the first month of treatment right after a child with ALL is diagnosed is very intensive. They receive treatment 2 to 3 times a week for the first month in inpatient. It's called the induction phase. So we will visit and take measurements very intensely for that first month, and then once every 2 months once they come into outpatient therapy. But they'll receive weekly animal-assisted therapy visits for those in the treatment group. And I should stress that this is not set in stone. This is still under review by all of our sites and by our funder, but this is what we hope will be happening in the fall. I think I already went through that, and I think I'm just short on time, so thank you.